Good afternoon, everyone, and welcome to session 3 of the COS, Moving Beyond 2020, focusing on impact and sustainability. And I'd like to welcome you to this session, and which I'm sure will be of great interest. And we'll try and match the what we've heard earlier in the session. But most importantly, we'd like to introduce our first 3 speakers. The first is Dr. Srinivas Iyengar, who's he's going to talk about scaling up capacity, building on subspecialty care with telemedicine. Srini is an oculoplastic surgeon and top doctor in ophthalmology and plastic surgery in the San Diego area. He spent 1 year teaching surgery around the world on the Orbis DC-10 flying eye hospital, and continues to serve as a mentor on CyberSight and the volunteer faculty with Orbis. Our second speaker is Penny Lyons, who's well known to many of us. She's been the executive director of SAVA Canada since 2006 and is committed to building sustainable, locally driven eye health programs throughout Asia, Africa, and Latin America. Prior to her work at SAVA Canada, she worked internationally as a management consultant and owned and operated a financial management company. Third speaker is Gareth Mercer, who's a resident at McGill University, who has completed his combined MD-PhD program at UBC with his PhD in population and public health. His research interests focus on designing and evaluating interventions to social inequities in access to eye health in low and middle income countries. So to move along, I'd like to go back to Srini Iyengar and ask him to give his talk on CyberSight and scalable solutions to global blindness. So Srini, over to you.
Hi, thanks so much. That was a very nice introduction. I'll be talking about CyberSight and some of the scalable solutions that we've seen with Orbis International. As you said, I spent a year working with Orbis as one of the ophthalmologists on their plane as part of the Flying Eye Hospital, and now serve as volunteer faculty with oculoplastics. And recently I was in Ghana, so I was able to use some of these things that we'll be talking about here shortly. Next slide. So the telemedicine platform CyberSight is established by Orbis, and what it allows us to do is consult and mentor different surgeons from around the world. And it also has a few other aspects of it, which is nice. It has online courses and a library of surgical videos, as well as lectures on topics concerning the subspecialty surgeon in different parts of the globe. The nice thing it also includes is, in terms of projects that we do abroad, a lot of the data that we get from the local hospitals or local eye surgeons, when we have volunteer faculty arriving, that data immediately goes into the electronic medical record. So around the world, we're able to view kind of what the cases are going to be before we even hit the ground. And so that's something that I saw in effect most recently when I was in Ghana as part of the Flying Eye Hospital project there in 2019. And then the third thing that's kind of exciting about this telemedicine platform is artificial intelligence and using it for diagnostic purposes in terms of determining whether or not people need certain types of care, or whether or not it's worth them to travel to get this care, as well as to help train other eye doctors in terms of recognizing things like diabetic retinopathy, optic nerve changes, or changes in the macula. In 2019, we got a significant number of organic consults, basically where the doctor presented these cases, and then an expert can sort of give back some feedback in terms of how to approach this. Over the 17 years of this project, it just started originally by Gene Helveston. We've seen over 30,000 consultations with almost 200 countries where people have registered users, and it's kind of nice, this global impact. In terms of like the top 10 countries that we can see people from all over the world. I think that graphic didn't quite show on this, but we can able to see people from anywhere from Mongolia through different parts of Africa as well. There we go. There's the graph. So yeah, this kind of gives you a representation of all the different areas that we're seeing these organic consult cases being submitted to CyberSight. And it's something that's very exciting in terms of providing a global sustainable impact with, web access now available around the world. There's not only on this website or this on CyberSight, not only are we able to discuss cases, there's also new courses, online courses where people can learn different surgical techniques. One new course that was added in 2019 was Fundamentals of Glaucoma. And certainly, in areas where phaco is not available, the fundamentals of M6 is still one of the most popular courses. This, in terms of what we've seen in terms of the surgical videos, we've seen a huge surge in people wanting to see surgical videos. 100% increase in library video views over the last few years. And then, the number one these days with videos being kind of the primary media platform to learn surgical techniques. We saw, the enucleation technique by, Santosh Hanavar in Hyderabad, India is the number one with over 22,000 views. It's really exciting for people around the world to be able to use this platform. The other thing that we have also is live teaching available now, and this is a webinar series that originally we started in Nigeria and Mongolia. And one of the most exciting things about this live surgical teaching is people can also direct their mentors and mentees. They can have this didactic session during the surgery, a live surgery, which is pretty exciting. And several of these people, they were mentors or mentees, and now they've become mentors. As you can see here, this is a recent session we had on Duane retraction syndrome. And these are people from different parts of the world. The two of them are from India, and so they both trained first as a mentee, and now they're mentoring other eye surgeons around the world in pediatric ophthalmology, which is very exciting. The surgical mentorship from a wet lab perspective, there's a which is pretty exciting, because a lot of the places when they're trying to practice surgical training on a wet lab, we all want guidance, and, practice, a famous philosopher once said, practice doesn't make perfect, perfect practice makes perfect. So, one of the things that was critical in this program was being able to link with Emory Hospital, where or Emory University, where guided training in terms of the wet lab could be done and reviewed. This, we can see here, the live surgery, the surgical mentorship going on here with Dr. Larry there, who's mentoring one of his first trainees while live surgery is performed. We tested this out on the field when being in two different rooms, and now live surgery can be mentored via the web, which is very exciting. Certainly during the COVID hiatus, we've seen a surge of interest in this platform in terms of, we've seen increased user views. We've seen more people accessing the online courses, and the webinar attendance, as you can see, has increased. We hope this continues even following the quarantine period. The AI, this is very exciting, as well as training doctors. A lot of these things are still reviewed with the mentee, in addition to the artificial intelligence recognizing things like dot blot hemorrhages, macular edema, optic nerve changes. The platform here is one of the few that includes not only optic nerve changes, but also changes in the macula, as well as recognizing diabetic retinopathy. Finally, after COVID, the exciting thing about this platform is we hope that it's able to access different parts of the world, where the internet access will be critical to providing the surgical training. And they certainly won't replace, being in person, but we're excited, and we encourage you to sign up at cybersight.org.
Thank you, Srini. That was great. So many of these things, I think, will have huge impact as COVID continues or doesn't ease up in terms of how we perform our global health program, which I'm really excited to have you as a speaker to talk to us more about that. We're going to move on to Penny Lyons, and she's going to talk to us about the cost recovery through revenue generation, 10% down, 90% to go. Can we have Penny join the stage, please? You're muted. Penny, you're still muted.
The host muted me. Now?
You're good.
Okay, yeah, I was muted by the host. That's you, Vivian. I'm going to be speaking about cost recovery in international eye care programs. International eye care funded by charities, individuals, and government health systems can meet only about 10% of eye care needs in the developing world. So as a result, most people who are blind are going to stay that way unless we find a new source of revenue to fund eye care programs. Next. We will never meet the needs of the 115 million projected blind people through donations and through surplus funds from governments. In the absence of adequate and reliable funding, Save Canada has championed a system for decades whereby fees from the wealthy cover the cost of surgery for those too poor to pay. But it's not enough. Eye care programs in developing countries need secure funding, independent of donors, wealthy patients, and government agencies for sustainability and program growth. A for-profit model is the only way to secure the necessary funding to meet population need. So where do we find the remaining money to meet the remaining 90% of eye care needs? From the patients. This is and isn't about making money. International eye care must be profitable, but not so profitable eye care is beyond a patient's capacity to pay. Eye care must also be of a consistent high quality, because even the poorest of patients demand high quality care. Next. Great. So here's an example about what donations can do. This is a small, just a second, I think we have gone one too far. Can we go back one? There we go, thank you. Here's an example of what donations can do. This is a map of Burundi. It's a small country in the middle of Africa, always listed as one of the world's poorest countries, with an average individual income of about $750 US annually. The provinces in red each have a community eye center, which are also called vision centers or primary eye care centers, depending on the country. They're a small standalone eye clinic that's very similar to an optometrist's office, which treats minor conditions, dispenses medicine and glasses, but also acts as a referral agent for patients needing surgery. Bujumbura, the capital city, has a general hospital, which performs very few eye surgeries, if any, as well as a private eye hospital that performs a lot of eye surgeries. 3 of the community eye centers were funded by Save Canada. The private clinic and 1 of the community eye centers were funded by the only active ophthalmologist at the time, Dr. Levi Kandeki. Next. So within 3 years of the establishment of the community eye centers by Levi and Save Canada, Burundian private investors, including Levi, built 22 more community eye centers in Burundi. Why? Because the first 4 CECs I showed you on the previous map were successful. High quality eye care was being provided at a reasonable price in the community, and the community eye centers were making money. Quite a lot of money given the poverty of the population. Now, not all of the community eye centers have survived, but the vast majority have. The green dots that you see on the map represent community eye centers owned and managed by Levi Kandeki, the ophthalmologist, and revenues from consultations, pharmacy, and optical shops accrue to him. Levi manages and owns the shops for the blue dot CECs, and these are in district hospitals. The yellow dot CECs are being assisted by Levi and are referring surgical cases to Levi's clinic. And the red dot community eye centers are in a WUTS group, and Levi advises them from time to time. The patients referred for surgery pay a sliding scale of fee where the lowest cost is free. Now, the Burundian experience is proof of concept that investment capital will create high quality, affordable eye care in the world's poorest and most difficult places. And we have similar data from other African nations as well. Next slide, please. In addition to Burundi, Levi has built 2 community eye centers in Rwanda, and Save Canada has funded the creation of community eye centers in Congo, Brazzaville, Madagascar, Benin, Malawi, and Uganda, as well as consulted on community eye center development in Tanzania, Mexico, and Guatemala. Next slide, please. SAVA Canada has found that the best way to provide consistent, accessible, and high-quality eye care is through community eye centers. Because they're located in remote and rural areas, they are accessible, which also improves gender equity. And if they're generating income, they will continue to provide care within a community indefinitely. Next slide, please. So, can CECs generate a surplus? The short answer is yes, definitely. This is 1 year of data from a community eye center in Rumonge, Burundi. You'll note that the year's surplus is about $73,000 US, and that money can be reinvested in further eye care in Burundi. Last slide, please. Global blindness continues to increase, and we don't have the funds now and probably never to treat the projected 115 million who will need care by 2050. Creating social enterprises in rural communities might be part of the solution. Thank you.
Thank you very much, Penny. That was an outstanding talk and very sort of instructive. So just move on to ask Gareth Mercer to give the paper on outreach screening to address socioeconomic barriers to diabetic retinopathy care in rural China. So Gareth, over to you.
Thank you, Simon, and thank you to everyone for coming to hear the talk. So I'm excited to share this work that I've been involved in with. Sorry, am I unmuted? I keep getting messages about it. Everyone can hear?
I can hear.
Okay. Okay, so please advance the slide. I'm happy to share this work that I've been a part of with Nathan Congdon as the PI, and in collaboration with ophthalmologists at the Zhongshan Ophthalmic Center in China, as well as collaborators at the China branch of Orbis International and at various institutions in the United Kingdom. None of the authors have any financial conflicts of interest to declare. Next slide, thank you. So China is the country with the highest number of people living with diabetes on Earth. And it's estimated that of rural older adults, about 5% have sight-threatening retinopathy, but only 10% of these people are actually diagnosed and treated. And so there are considerable barriers to overcome in trying to provide screening, which is a vision-saving intervention to these people. One of the most significant ones for rural individuals is that at present time, screening is really only available in secondary and tertiary level hospitals in cities. And although most of the population is covered by a government-sponsored health insurance plan, the direct and indirect costs of reaching care for rural dwellers are still significant. And it's been shown that this affects those who are most vulnerable in society, including women, older adults, and those with lower levels of education. Next slide, please. So one effort to try and overcome these barriers has been through outreach screening at the level of rural clinics. And one such intervention has been put into place since 2017 as a collaboration between the Zhongshan Ophthalmic Center and Orbis International in the Guangdong province, which is shown in the map here. And essentially what this program does is that it offers free eye screening examinations and education about the importance of these exams to all of the patients registered at a township health unit with diabetes mellitus. Next slide, please. So our hypothesis was that primary level outreach screening in this method will improve the representation of traditionally underserved groups as compared to the current standard of care, which is through passive case detection through secondary level hospitals. Next slide. And so we addressed this question by comparing 3 different cohorts of adults with new or previously diagnosed diabetes in the Guangdong province. And they were collected as parts of 3 separate studies, but with similar inclusion criteria and data collection protocols. And so the first group of patients that was looked at represents the current standard of care in China, and that's the passive case detection group, which is composed of consecutive patients presenting for eye examination at 5 different county level hospitals. The second cohort, which is the outreach screening group, were based on consecutive patients presenting to a single township health center that was participating in the Zhongshan outreach screening program. And then the third cohort, which is our reference group, was based on a population-based cross-sectional study of diabetes prevalence in the province. And so what our statistics involved were comparing the 3 different cohorts in terms of the representation of these traditionally underrepresented groups: women, adults aged 75 and older, and those with primary level education or less. And we compared them across the 3 cohorts with the population-based cohort as the reference. We also looked at the rates of sight-threatening retinopathy using a similar fashion. So next slide, please. So this figure summarizes the principal findings of the study. On the y-axis, I'm showing the prevalence of the 4 different variables standardized to the level in the population cohort, which is reflected in the darkest bars on the left-hand side. And then in the other colored bars, we have the outreach screening group in the middle, and on the right-hand side of each variable is the passive case detection group. And so what you can see, as has been shown previously, the passive case detection, or the current standard care pathway, is significantly less likely to detect or to represent people who are women, older aged, or with lower level education. In contrast, outreach screening was significantly better at representing those with lower level education, and had a tendency to represent older people to a greater extent as well. And you'll notice that women are equally likely to be present in the outreach screening group as they were in the population-based cohort. Interestingly, we also saw that the outreach screening group was significantly more likely to have sight-threatening retinopathy than either of the other 2 cohorts. Next slide, please. So in summary, outreach screening, as compared to the current care pathway for rural Chinese people with diabetes, improves equity of access to what we know is a highly effective sight-saving intervention, and also improves the ascertainment of those who are at greatest risk of vision loss. Some future areas for investigation include looking at the influence of community-level factors like the integrity of the public transportation system and of the public healthcare system, as well as looking at the cost effectiveness of this intervention. And here there's a role, as Srini was alluding to looking at how telemedicine and artificial intelligence can help to decrease the burden on ophthalmologists for providing this type of screening. Last slide, please. So I'm very happy to answer any questions you have about the study, either as part of this session or by email. So please feel free to reach out.
So just to remind everyone in the audience, we'll be using the QA function on the bottom of your screen for any questions from the audience. If you open up the dialog box, feel free to just type in your question, and our moderators will be happy to post these to our speakers. And just to get us started, the first question that came in from the audience, and I think this probably goes to all speakers that had just spoken, what is the role of vision care in the North within global ophthalmology? So I think I'm going to reframe this question to say, I think what they're trying to ask is, how does global ophthalmology impact the global North instead of just the global South, which has been addressed in the first 3 talks?
I'm happy to make one comment about that, although obviously very happy to hear what the other members of the committee have to say. But I think, you know, this is a common question for people who are interested in getting involved in international health or global health. And I think it's very important for all of us to recognize that within our higher income societies, there are still huge inequities in health that need to be addressed. And so for me, when I consider the types of research I'd like to be involved in, looking at how to overcome social inequities in health, I don't consider these as really being based solely in lower and middle income countries. I think of those as being also applicable to high income settings, although the nature of the interventions may be distinctly different. So I think there is certainly an important role for the types of thinking and approaches to global ophthalmology in high-income countries.
Yeah, and just to kind of clarify and follow up on that, I think the question, the person who asked the question also is particularly interested in indigenous health, and maybe Dr. Martin can speak a little bit around this area.
Thank you very much, Dr. Yin. That was Dr. Mercer's point in terms of the power public health, particularly to reach underserviced areas, applies very well to Indigenous communities, which, as we know on this particular virtual meeting, oftentimes have the worst health outcomes, particularly in Canada, but that's a global phenomenon, and also have some of the least access to quality, affordable healthcare. So thanks for highlighting Indigenous peoples as one of the underserviced, under-recognized, and neglected communities in ophthalmology and indeed global health.
Thank you, Dr. Martin. Does the panelists have any questions I want to pose to one of the speakers?
Vivian, if I could just add on a little bit to what Dr. Martin said, I think there is considerable work now being done that we don't know much about. It's a bit fragmented, but certainly in the downtown east side of Vancouver, the blight of the urban poor in our cities in Canada. And again, there are ongoing efforts to address that. Also, in terms of the North, I think that we have sort of initiatives going to try and build on, what's already there and strengthen them. For instance, the Save Orbis ideas about helping in the Northwest. So it's just I don't think we put much attention to these initiatives, or already evaluated them in great detail, but it seems to be in the works anyway. I'm sure we'll be hearing more about it in the next few years.
And I see that we have a couple more questions coming in. Sorry, go ahead, Dr. Cherwick.
No, take the panel question, the questions from the audience.
So there was a question, I think, addressed to Penny Lyons, asking about specifically CEC working in Rwanda, that it seems that access is still limited by costs, and that the work is equivalent to optician and with some limited ophthalmic knowledge. And maybe you can comment a little bit more about what has CEC access been like in the areas that you are aware of.
Okay, so it's actually not an optometrist often, it's like an ophthalmic assistant. So someone who's got a bit more training than an optometrist, because they can also prescribe, they will prescribe medicines, but they'll have a bit more extensive training, I think, than an optometrist often. But it's a similar setup as an optometrist office. The care is more affordable, typically in Rwanda, at least in the CECs that have been created, in that the center is in the village. The people have access to it. The prices are based on what the villagers or the surrounding population can bear, and because they have a understanding and they know who the person is who's running the CEC. It's someone from the community. Then there's adjustments that can be made in terms of cost and need for care of that particular individual.
And as a follow-up, Penny, there was some interest from Ralph about how is the financial subsidized model work with capital costs and running costs, et cetera. So I think the question is more the breakdown specifically of how does cost get subsidized, and how much, I guess.
Well, so the costs aren't so from an external source, say from Save Canada, the costs aren't subsidized within the Community Eye Center. So we might provide the funding to help create the Community Eye Center and help support in terms of providing money for the equipment and maybe for the initial stocking of it. But it's not that the services are subsidized by anyone. It's just the services are lower cost because the costs are simply lower in that country. So the services are priced at what the market can bear for that particular area. Just like any business that's opening up, you're going to price your product or service at a point where the customer can actually pay. And that's what happens here, is that the service is provided at at a market rate that the person can pay. So they'll have very expensive glasses, but they'll also have very inexpensive glasses. Surgery is a little bit different because it's typically a referral service, and so that it would be negotiated, with the surgeon, but that's typically also on a sliding scale, so that the people who can pay very little will have a reduced price. I hope that answers the question. I'm not sure.
If there's time, there's another question that, aside from Orbis, how do we build capacity to actually develop sustainable eye care in rural Canada, particularly for Indigenous populations? Anyone of the like to take that one on?
I think a common theme, and I really appreciated Penny's talk about creative models for financing. I also think we need to look for force multipliers within the tech sector. Certainly, I think AI and telemedicine can kind of help with the concepts of distance. I mean, when you look at cataract blind or diabetic blind, it's always A, B, C, D. Is there awareness? Are there bad outcomes? What are the costs? And what is the distance? I think Penny's model really addresses the cost. I think telemedicine is something that can obviously address the distance. And when you have, training like either distance learning or blended learning, the outcomes tend to improve. And certainly with media and social media, awareness and advocacy are becoming even more important. So I do think we have tools now in hand to kind of address the ABCDs of avoidable blindness, whether it's in, northern Canada or in sub-Saharan Africa. It's exciting to see how flat the world has become with tech and, like Penny has highlighted, innovative financing solutions.
Thank you, everyone. For the questions we didn't get a chance to get to, we'll have another crack at them at the very end, where we have a much longer QA session. It is with very great pleasure that I would like to introduce our keynote speaker for CAFGO session this year, Dr. Keith Martin. Dr. Martin is a founding executive director of the Consortium at University for Global Health in Washington, D.C. And between 1993 and 2011, Dr. Martin actually serves as a member of parliament in the House of Commons, representing Vancouver Island. He also held multiple shadow ministry portfolio, both in foreign affairs, international development, and health. And he also served as Canada's parliamentary secretary for defense and was appointed to the Queen's Privy Council for Canada. His main area of focus are in global health, foreign policy, security, international development, conservation, and the environment. Dr. Martin has served on numerous diplomatic missions to areas in crisis and served as a physician in South Africa on Mozambique border during their civil war. He has traveled widely in Africa, visiting the continent more than 30 times. He has had over 180 articles published in major newspaper and scientific journals. He frequently also appears as both a political and social commentator on television and radio. And I know him through CUGH, which is really a great organization that we're hoping CAFGO can partner with more in the years to come.
Dr. Yin, thank you very much for your very kind and gracious introduction. Bonjour à tous to everybody on this particular online meeting. And I really want to compliment you, Dr. Yin, for you and your team for pivoting so seamlessly from an in-person meeting to this virtual meeting. We're going to learn a lot from you in what you have done. So I know you've been a tireless worker. So thank you very much for the invitation, for your hard work and that of your team. When Dr. Yin when Dr. Yin invited me to give this talk, one of the things that we spoke about was, of course, how do we make sure that we can amplify the great work that's being done right now to reduce blindness internationally, because that was then and this is now in a COVID world. So what I'm going to do is just talk to you a little bit about, share with you a few observations of things that I've learned being here at the Consortium of Universities for Global Health, and how we can maybe take the work we're doing and perhaps be a little more effective in our partnerships that we create to, again, deal with the focus of this particular part of the meeting, which is on impact and sustainability. So the next slide, please. And of course, this is our goal. And I think all of you know that back in 1999, Global Vision 2020 was to eliminate avoidable blindness by 2020. Next slide, please. But we're not there, and we're, as we've heard during the course of today, that we are actually have a long way to go, and in fact are falling behind for multiple reasons: our expanding population globally, aging population, non-communicable diseases, particularly diabetes, are all having an impact to really have increasing the number of people with blindness and visual impairment. And as we heard earlier, the tragedy of this is, as one of the speakers said, is we actually know how to address these challenges, but despite that, blindness and visual impairment is a neglected global health challenge. So let's change that. And that's how what are we gonna do about that? So if we can go back one slide, please. So just briefly, as we've heard, 2.2 billion people are blind or visually impaired. And of these, over 1 billion cases were preventable or treatable. The one really interesting thing is, as low-hanging fruit, unaddressed presbyopia affects 826 million people. 80% are in Africa. And in the WHO's World Report on Vision, as has been repeatedly referenced in today, does a great job of actually showcasing that this is often, it occurs in every country, but particularly in low-income countries, and also in underserviced and individuals in high-income countries. So this is really not only a health issue, but it is an equity issue and an economic challenge. Next slide, please. And I would challenge anybody that, although this often fits within the Sustainable Goal 3, I would challenge anybody to tell me any of those sustainable goals in which vision is not a part of. And I think we can make a very concrete argument to say visual health affects every single sustainable development goal. Next slide, please. So this is the way we were up in the top left-hand corner, but how far have we come from those days of in the past? Where are we today? Well, certainly a lot has changed. A lot of good things have happened, but we still have a long way to go. So let's take a look at some of those things. Next slide, please. I took this picture. I was in one of the largest teaching hospitals in sub-Saharan Africa, which I will not name. On your left is the outpatient department, and where there's no soap, the equipment is a very poor quality. There's blood on the floor. On the right are where our colleagues, the residents and trainees and those working overnight, sleep. Windows are broken, toilets don't work. The reason why I brought the slide up is that this is an institution that is well known, where we from high-income countries go to have training opportunities, engage in research, and we've been here for decades, and yet these conditions exist right under our noses, and that shouldn't happen. It can change, and it can change through partnerships. Next slide, please. So overseas volunteering, and I won't belabor this, but it's a lot of people do it, but most of the engagements we have are under 2 weeks, particularly in the medical area. There's little accountability for our actions, and we still, to this day, a lot of it is what we are doing for them. That needs to change. There's also very little pre-deployment training and little consideration on what is the key issue of this talk, which is the issue of sustained capacity building in the countries and areas we're working in. Next slide, please. So we have to, I think, acknowledge, if we go back historically from where we're coming from, particularly if we're coming from high-income countries like Canada and go to low resource settings, we have to acknowledge that we're coming from a position of unequal power dynamics that existed in the past and still exists today. And we come from an area of privilege. We're usually taught by colleagues who are from high-income countries. And we have to also acknowledge the painful historical conditions upon which we went to those countries in an environment of racism and classism. And that there are deep disparities in the resources we bring to where we are. And we can leave when we want, but the folks we work with in these environments, they're still going to be there when we leave. And also a very important thing, which I find we perhaps don't consider enough of, is when we are in when we're in low-income environments, we're actually using resources that are there. We're there to help, but we are also using resources in those communities. Next slide, please. So first, what not to do. We all know as physicians, do no harm. We also often fail to engage in pre-deployment training to understand the social, economic, and political conditions that you're working in. If you're going to be effective in those environments, you have to understand the environment you're in, and you're not going to understand it before you go, but at least start to have some understanding about what you're getting into. Believe it or not, and I shouldn't have to say this, but don't operate beyond the scope of which you can practice in your home country. I'm saying this despite the fact that, shockingly, this does happen not infrequently, where people are operating beyond what they're allowed to do in their home countries. Don't be paternalistic, causing harm to the host institution, being a prime beneficiary of your project, and believe it or not, diminishing the authority of local healthcare providers. So we have to be really sensitive about who we're working with and in that context. Remember, we have one mouth and 2 ears, so we're going to use those 2 ears first. Next slide, please. Our colleagues at the Uniformed Services University of the Health Sciences, which is the military university here in the US that does a great job of training a lot of their physicians. 7 surgeons from there were so frustrated. They put these 7 sins of humanitarian medicine. I think that I'll leave it there just for a second, but a couple of things apropos to this conversation is, one of the things on the ground is that there's still a failure to communicate and cooperate with each other as groups on the ground. And I think we need to do a lot more of that. And again, do no harm. That has to be paramount in what we're trying to do. Next slide, please. So what to do? I mentioned the do no harm. Please do access pre-deployment training. Listen, be humble in the local environment that you're in. Work hard, follow the rules, operate within your scope of practice. Above all else, as guided by our colleagues on the ground, and this is really critically important, obviously, they have to lead. We are there to be supporters of what they want to do. They'll let us know what, if anything, we can do, but we have to be guided by their interests. And I think we heard earlier today, and I'm sure it was Dr. Holland that may have mentioned this, that 191 of 193 country plans for health don't include eye health. So we have to work with our colleagues overseas and really, I hope, encourage that data and that information to be there to understand, for them to guide us on what they need and how we can work effectively with them. Such things really cannot come effectively from outside. Capacity building, again, is just a key element, and believe it or not, it's often missing in global health. Next slide, please. I put this slide up. It's actually, I'm here about 1 kilometer from the White House, but this is actually about 1.5 miles from the White House. And I put this up only to reinforce a message that is in the UN World Report, that a lack of access to quality, affordable eye health is not only an issue in low-income countries, it's also an issue within high-income countries too. Next slide, please. So here's some opportunities, and our community in the Consortium of Universities for Global Health are academic institutions. So I put this up for those of you who are part of an academic environment. We have an opportunity, particularly now in the COVID environment, to leverage this moment to be able to build effective partnerships and to work with our colleagues to frame it so that the benefits of those partnerships accrue to our colleagues overseas. To build and focus on local capacity building, to create bi-directional opportunities for train and share innovation, to create more opportunities for collaboration on research and grant writing. And finally, an area that's often missed is the whole issue of strengthening public institutional capability. In low-income countries, ministries of health are really strapped for often for effective trained people to help them build and operationalize what they need. If they want this, we should be able to collaborate, if they want, to work with them to strengthen their own institutional capacity to fund, manage, and operate what we need to do to improve access to better visual health. Next slide, please. So again, building and sustaining local capacity. This is a time when we can do this at a distance while things are shut down in terms of travel. I would just consider also a number of speakers have masters in public health, which is absolutely fantastic. But I think we need to do a better job of engaging public health, public administration, and also nurses. We were talking about a WHO report on the state of the on the report on vision. Another seminal report came out this year on the state of nursing and midwifery. 59% of healthcare workers are nurses. Maybe we could think about working with our nursing colleagues in terms of the prevention side of and the screening that is so important for improving eye health, as we've heard earlier today. Next slide, please. So this is our goal, as we've seen before. It was the goal in February 1999. It is our goal today. Next slide, please. And I just draw your attention to these resources. I would also I thank Dr. Judy Lasker, Professor Lasker from Lehigh, has done a lot of work on the promises and pitfalls of global health volunteering. If you want to know how to build, be a better partner, be a better collaborator, build better partnerships, I would encourage you to look at Professor Lasker's work. And Dr. Yin, I think I'm under time, and I thank you very much, and I'll turn it back to you. And thanks for your attention, everybody.
Thank you, Dr. Martin. That was incredibly on time, especially when our last session ran a little bit over. I'm going to open up for Q&A just for 4 minutes, just for Dr. Martin's talk. And then we actually have a very exciting panel discussion coming up right after this. But I'll get Simon to get started.
Yes, Dr. Martin, fantastic talk as we expected, so thank you. But do you think there's any way we can harness the enthusiasm and of our colleagues in privileged countries like ours to go and do the right thing, as it were, in all the, and try and avoid the mistakes that you mentioned in your talk? And what is the best way the average practitioner in North America or Europe can help, do you think, in trying to do something to help the blindness in developing countries?
Well, thank you very much, Dr. Holland. It's an excellent question, and congratulations on your Lifetime Achievement Award too. Well deserved. And so, I think the first thing is we have to bring vision and eye health to the forefront of global health. As was mentioned earlier, perhaps by Dr. Yin and others, it's not there. And we at CUGH need to do a better job. Others in global health need to do this. So part of it, I think, Dr. Holland, is for those ophthalmologists, optometrists, and others to assert politically to have greater investment, attention, and to integrate access to affordable quality eye health into not only our country and Canada, but also encourage our colleagues and work with our colleagues, our other health professionals, to be able to do that within their own countries. And secondly is to work with perhaps existing partnerships, to strengthen those partnerships particularly across education and capacity building, not only in the biomedical area, but on the non-biomedical side, the management side, which we found, at least here at CUGH, is a huge unrecognized gap in being able to have the platform to be able to provide better health care, whether you're talking about vision health or some other area.
Thank you very much.
That's a great segue to actually one of the unanswered questions from earlier, which I think is perfect to be addressed at this point. And Dr. Martin, this is about training. So as someone who is deeply involved with academic global health, we know that because of COVID and all the travel restriction, that's been significantly compromised. So how can we continue to address training and capacity building in global ophthalmology when we're all grounded, so to speak?
I think for Dr. Srinagar's comments earlier, the online component, I think first it's building relationships that you have with those who are trying to provide better eye health, access to eye health in low resource settings. Second, it's being able to, I think, capture, aggregate the kind of innovations that Dr. Iyengar had provided to show us, and Dr. Mercer and others, being able to aggregate those and make them open access and available to all. The other side is in terms of the skill set deficit in global health, and it's not what we may think. So in the data that we've looked at, it's actually things like project management, cultural competencies, leadership, communication, partnership development. They sound like soft things, but honestly here at the National Institutes for Health, one of the head of the Centers for Translation and Innovation, he said, look, most partnerships fail not because of a lack of knowledge of science, it's actually because of a failure of the social sciences in implementing a project. So I think we're all busy in the training, but if we can provide some of that training and make it open line and accessible using the tools that we've heard today, that would be really quite remarkable. And use this time to plan out in terms of building relationships with our colleagues in LMICs to create the work plans that we can actually start to execute over time.
And that's actually a perfect segue to this panel discussion that I've been very excited about. So, you know, we can't have a session during COS without at least talking a little bit about COVID and the impact of COVID on whatever the topic it is. It could be cornea, it could be global health, it could be neuro-ophthalmology, whatever field of medicine you think about, you can address how has COVID impacted that. And that question we just heard Dr. Martin beautifully answer start to allude to that. And I'm gonna actually introduce our other panelists on this discussion, Dr. Hunter Cherwijk and Dr. Cam Bassett. Now, both of them are very well known to the audience because of their decades and decades of involvement in global health, but I think they're also the two people that are most known for building bridges, which goes to Dr. Martin's earlier points, totally unplanned. But Dr. Cherwijk is a global ophthalmologist with specifically dedicated his entire career to how to train and how to use technology, as some of you heard earlier, to eliminate avoidable blindness in low resource communities around the world. He is currently the VP of Clinical Services at Orbis International and has been a very influential figure in ophthalmology as one of the 2020 Power Listers. Dr. Cam Bassett is a professor of medicine at the University of British Columbia and also program director for SAVA Canada and director of BC Center for Epidemiology and International Ophthalmology. He's published extensively on how to build sustainable global health programs through continuous monitoring and evaluation. And with that, I'm gonna ask the two of them to comment on the question that has already been posted, which was, how are we gonna still be able to do training and capacity building in light of COVID? And I know all of our programs been grounded and none of us has traveled since probably January for most of our program volunteers.
Ken, would you like to go first on that?
Sorry, should I go first?
Yes, why don't you go first, then I'll follow.
So Vivian, yeah, thanks for the question. And what we found with our program partners in South Asia, and mainly India, Nepal, and Cambodia, we found that there's been a real opportunity for teaching. The whole program has gone on pause. And they've been available now to work with us on a whole range of operational research projects, operational learning projects. We have a whole quality assurance project. They're now, we're on Zoom calls. They're very excited about it. They come with their questions. They come with their progress. So it's actually been a real pleasant surprise and a real opportunity for growth among the programs with one another and with us. So it's there's a real a benefit in some ways for education with COVID.
Yeah, I fully agree. I think we've had a huge bump in our e-learning, our webinars, as well as interactive. I think Dr. Iyengar spoke about this. We have connected wet labs where now residents are going in and having a mentor either in the US or other centers, working with them one-on-one, and now taking that into the OR when they go back to their OR to treat patients. So while international volunteers like yourself, Vivian, may not be going to Nepal and doing the training shoulder to shoulder, we are finding that this remote telementorship program with live surgical coaching has been really successful. And I've really been impressed with the proctored or mentored wet labs from afar. So a lot of the residents are just like here in the US are not the front line always for ophthalmology, that they're using a lot of this time to get in the wet labs, get on the courses. And to me, that's really exciting where you can still have that contact and that EQ that Keith talked about and re-coaching them about how to hold a handpiece or things like that. But obviously, we're still very much looking forward to complementing that with in-person training in the second half of the year.
That's great. And to kind of follow up on that, Dr. Cherwak, you know, there's been a lot of question about teleophthalmology that came in throughout the entire session. And I personally had a question for Srini earlier that I never got to ask as well. So I'll punt the question to you. You know, the live surgical mentoring sounds very exciting, but it sounds like it also needs a lot of technical requirements. How do you even manage to do that? How do you pick the right candidate to participate in programs like that? And how do you even evaluate for outcome in terms of whether the skill set has been acquired or not?
Yeah, that's a great question. And that article in the upper right-hand corner of his slide this is a peer-reviewed published model. So this was with our partners in Peru. We usually do not start with remote surgical mentorship. It is after the two have established rapport and after they've done in person and following what Keith said, it's really what do you do afterwards? What do you leave behind? And so for us, many of the times we install, and the tech has gotten to be pretty low cost and pretty high fidelity. The lag time we've actually optimized with some of the works from our IT team, but it is exciting where the doctors, like I know you've been to Nigeria and Nepal several times, where you can continue to follow them 2 weeks, 4 weeks, 6 weeks afterwards. And we use the ICO's rubric, the Oscars, to do that, for example, phaco. And so we are still tracking and grading their surgeries, and it's the same grader, the same mentor. So it's really kind of following the relationship they established in person, the trust that they had in person, and then continuing that online.
And there's a follow-up about, you know, we're all becoming more acutely aware about confidentiality and privacy with electronic transfer of any sort. So a question came in from the audience as a follow-up that how do you deal with confidentiality with these platforms?
Yeah, so most of our, Ken, I'm sorry, did you want to answer that first?
No, you go ahead.
These are all de-identified. So there's no patient data, patient names, unique identifiers discussed. They're really starting the case, you know, with the eye under the microscope and going through. The case discussions can occur, you know, and these are not broadcast. This is one-on-one linkage. The live webinars and of course the courses do have case scenarios, but again, all of that is de-identified. We're acutely aware of the importance of patient privacy and of course working with data across borders.
That's great. Switching gear a little bit, I wanted to come back to this concept of ethics, which we talked about a little bit during the last COVID session. You know, what is NGO's role in view of COVID in terms of ethically, what are our obligations to our local programs in helping them deal with COVID, deal with infection control? And, you know, Dr. Martin alluded to that a little bit during his talk already. So I'll open this to all three of our panelists.
Shall I go first again?
Don't all jump in at once. Go ahead, Ken.
Sure. So with our program partners in country who we work through and support, what we've found is there's actually very little for us to do. And what we realize is how complex, how variable, and how rapidly things are changing in country. So we are really stepping back. We've changed our funding. We recognize it's going to cost more to provide any care they can provide. We recognize they're not going to be doing outreach. They're going to be doing, it's going to be passive care for the next, well, who knows? Things are getting worse in all the countries that we work in. So we're just stepping back and recognizing their expertise and their knowledge. And we really haven't had much useful advice for them so far.
I don't know if Keith wanted to go. I would say on CyberSight, one of the things, our Flying Eye Hospital is accredited by an agency called Quad A. They're based out of Gurnee, Illinois. They have provided us with all of their policies and templates, which we globalized. Literally one day after posting them on the CyberSight library, we had hundreds of downloads and dozens of countries accessing this. So I think many countries are starved for what are potential standards or practices. And then we followed those with webinars from some of our key thought leaders, medical directors, hospital administrators in India at very high level institutions that provide guidelines for all India. And they were talking about, things with regards to consumables, reuse, how to minimize and maximize dollars or rupees in that case. So I think that's been very helpful, where we've been able to globalize international standards and then provide webinars and one-on-one mentorings with hospital directors on how you customize that to local context and resources. Again, we are providing travel standards, and we're looking at everything from how do we test doctors before they go, and so that they're not a super spreader when they're there, but they're also safe. So we were just recently speaking at the World Economic Forum with some very interesting new testings that can be done within hours, and how that can be done to protect both the host as well as the international trainer or staff.
Thank you, Dr. Cherwak. I know Dr. Martin's video is frozen, but I think he can still hear and speak. So Keith, do you have anything to add in terms of ethics and standards in view of COVID?
Thank you, Dr. Yin. I think as Dr. Cherwak said, we have to listen to what our partners are seeking, to be there for them and support them in whatever they want. I think that's a wonderful list of assets that Dr. Cherwak has listed. The other side, just we haven't spoken about, is just on the advocacy side, just bringing up the eye health and vision health into the forefront of decisions that are made with regard to health. And I think this is a chance for us to collaborate with our colleagues overseas and being able to do that.
Thank you. Well, I just want to thank all of our amazing speakers, and I'm so excited that there has been lots of engagement.